Good evening and welcome. We'd like to welcome all the members of the District 2217, my colleagues from Southland College Prep Charter High School and School District 162, and the members of the District 144 families. You've chosen to join us this evening undoubtedly because you have questions regarding the recently approved vaccines for COVID-19. And we know it's so important that we have accurate information so we can make decisions and choices for ourselves and our families. To address this topic, we're very pleased this evening to have Dr. Watson here to speak to you and answer frequently asked questions that are most relevant to our group. So let me introduce him. Dr. Richard Watson is an emergency medicine physician and distinguished as a fellow of the American College of Emergency Physicians. He graduated with honors from Howard University College of Medicine and did his residency at the University of Chicago, where he was distinguished as the first chief resident of emergency medicine. As the first Black chief resident of the University of Chicago, Dr. Watson has served in the Chicago area as chairman of emergency medicine for several hospital systems. 6 years ago, Dr. Watson formed his own emergency medicine staffing company called Emerge MedStaffing. His company has grown into 3 divisions, which now includes telemedicine for online medical consultations and treatment, and most recently, a COVID screening division, which has provided over 10,000 screenings from New York to California, from Illinois to Mississippi. Dr. Watson is also a regular medical advisor for the Ed Lover Morning Show on 104.3 FM radio. Now, we met Dr. Watson and his team early this fall when his team provided on-site flu vaccines for employees in District 162 in Southland. A few days ago, we reached out to him for information and advice regarding the new COVID vaccines, and he agreed, and I should say, in fact, he offered to speak to you directly with facts regarding the vaccines. I should tell you also that his office offers rapid COVID testing at his Hazel Crest office. So we were happy to know that. This evening, our format will be Dr. Watson will make a presentation and he's going to address questions that we previously presented to him from our staff. If you have additional questions that would be of general interest to this group, please put them in the chat and we'll present as many of those questions as time allows at the end of his presentation. At the end of our presentation today, we're going to hear from our superintendents, Dr. Thomas and Dr. Davis. All right, Dr. Watson, let's get started.
All right, very good. Thank you so much for that. So I think I want to start with just some of the basics, and then we'll try to follow the timeline and bring ourselves up to date. And then we'll get into the vaccine and sort of where we are with that, which many of you know changes on a day-to-day basis. So let's take it back to 2019, December 2019, Wuhan, China. It was noted at the time that a SARS-like infection was breaking out in the area. At that time, it was contained in the Wuhan area, but as we all know, quickly spread outside of that area. Approximately 1 month after the virus was identified as a coronavirus, the scientists who detected it were able to map that the genome for that virus. So they had the entire DNA sequence for that virus. The virus named coronavirus is not a new virus. We have had corona on this planet, as far as we know, as long as there's been humans on this planet. what makes the virus so popular today is its mutation and its new form. The virus itself, known as the coronavirus, it's named after the way the virus is structured. On the external parts of the virus, there are these crown-like structures. These crown-like structures are called surface proteins or surface antigens. Remember that, surface proteins. Those are those kind of stalky, bulky protuberances from the virus. Those surface proteins, surface antigens, are what gets into the nasal cavity and adheres to the nasal mucosa. The virus itself tends to live in the back of the nose. And we've all had corona in the past. I'm sure it's not a unpopular virus. We just know it to be something that causes a cold or sniffles or nasal congestion. As I said, the virus lives in the back of the nose, what we call the nasopharynx, somewhere in between the nose and the mouth. And every fall, many of us encounter it. We get cold symptoms and we get over it. No big deal. Not enough to even recognize the name. What has changed is that surface protein. For whatever reason, the surface protein has mutated and it's become slightly smaller and has now been able to progress past the nasopharynx and down into the lower respiratory tract. The lower respiratory tract being your trachea and your lungs, okay? In the lungs, that virus is now causing an infection, which subsequently turns into a pneumonia. And that's why people are having these severe respiratory problems when they get it. That's why they're having fevers. That's why they're having the body aches and the systemic effects of having a virus in their system. Again, going back, previously, just upper respiratory stuff, nasal congestion, maybe even a sore throat, runny nose. Mutation occurs, those surface proteins change shape, and now that virus can travel further into your respiratory system, causing a lower respiratory tract infection, i.e. a pneumonia. The other aspect of this that is new to us in the medical community is the fact that this is not just causing an infection. This virus gets down into the lower respiratory tract. It becomes systemic, meaning it goes out throughout your body and gets into other organs. And once it's there, it causes an inflammatory response. And that inflammatory response causes the body to attack the tissue. So if it's an inflammatory response in the lungs, the body's immune system, recognizing that it's in danger, recognize that something is endangering it, sends its white blood cells and cytokines to the area that is infected, and it attacks it viciously. That happens whenever any of us get sick. That's a normal occurrence. In this particular case, this inflammatory reaction is exaggerated. As a matter of fact, we've named it a cytokine storm, just to properly define what's going on. It's excessive, and that excessiveness causes scarring in the tissues, such as the lungs, the kidneys, the liver, and even the heart itself. So we're quite concerned as a medical community about the effects of a person with COVID-19 or a corona SARS-CoV-2 infection. We don't know how long the tissue will scar for, if it's permanent. We don't know what the lasting effects of those scars tissues may be. I can tell you that scar tissue is not good, particularly in those delicate organs. And as a physician, I'm quite concerned about the long-term effects of somebody who has had coronavirus. it's been recently found, and this was found and published out of Texas just the other day. One of our colleagues, trauma surgeon, uh, had documented what we've all been seeing, which is patients who have been infected with coronavirus um, are showing signs and evidence of continued organ scarring, in particularly in the lungs. We've even noticed this in patients who were asymptomatic patients. So those are patients who, although they had coronavirus, it was detected that they had coronavirus, probably through an antibody test. Um, and they never had symptoms. They didn't have fevers. They didn't have shortness of breath. They didn't have loss of taste or smell, any of those things. They too are suffering some degree of organ scarring. That's quite worrisome, because up to this point, we thought that if you didn't have symptoms, that meant that you didn't have much in the way of tissue damage. We now know that to be different. So having said that, those things for me as a physician are concerning, not just for today, but for what's going to happen to those people in the future. So that's a little bit about the virus itself. I would like to go into just a bit about what we've done in terms of trying to detect the virus, get into testing, because testing is still a very, very important part of our daily lives at this point. And it helps us to try to manage the disease at this point when our resources are limited. We first developed antibody tests for coronavirus in actually late February, and they really hit the US in early March, most of them coming from Asia. The PCR test is probably the most popular test and is considered a gold standard test for detection of coronavirus. That's the test where they're putting a swab in your nose to try to get traces of the virus's RNA. That goes to a lab, and in about 48 hours, sometimes 72 hours, sometimes longer, that test can reproduce the virus's RNA if it was found in you, and that's a positive test. So if that test can duplicate the virus, then we know that you are infected with the virus. The second test that came out was the antibody test. And we use the antibody test to determine whether or not you had current infection or if you had past infection. The antibody test is divided into two antibodies. The first, and what we call acute phase antibody, is IgM, immunoglobulin M. And that occurs at about 4 days into infection, all the way out to about 2 weeks, 2 to 3 weeks. If, in fact, we see somebody with an IgM marker on their antibody test, we have very high suspicion that they are actively infected with coronavirus, actively infected, okay? If we have somebody with the second marker, which is IgG, immunoglobulin G, immunoglobulin G is a late phase marker. Immunoglobulin G pops up at about 14 days of infection and lasts significantly longer. It lasts, in this particular virus, on average, about 90 days, about 3 months. That IgG is a longer term protector. If you think about, let's think about it in the military sense. Let's think of IgM as the Army and IgG as the Marines. So when the virus gets into the body, gets into that posterior nasopharynx area, and those surface proteins stick to your mucosa and start to invade your body, the body alerts its immune system and says something's wrong, go call for help. The first to arrive is the Army, right? Army is the first on the scene. The Army assesses what's going on. They have reconnaissance, they have spies, they're taking pictures, they're getting a layout of the land. And while they're fighting, they're using that information and they're bringing it back to the Marines. The Marines is taking all that information and discovering where the weaknesses are, where the locations are, and it's building up their forces. After about a week or so, a week or two, the Marines are ready to release. In other words, the IgG is ready to release. And when the IgG comes in, it really comes in and cleans out. It just takes care of everything. So the IgM is kind of holding on to them and trying to keep them at bay, getting that information. IgG comes along and clears the slate to the best of its ability. And that lasts, it sticks around after that. It doesn't go away. It says, okay, we're here just in case it wants to come back. Unfortunately, in this particular scenario, it doesn't last long enough. It only lasts for about 3 months. So that's the antibody test, and that's IgG and IgM. And that'll be relevant a little bit later in the conversation. The last test that's come out and has been the most helpful test is the antigen test. And the antigen test also goes into the nose, the nasal cavity, and it detects for that surface protein that the virus has. You sweep it through the nose, and then you put it in a solution, and antibodies in that solution will bind to those surface proteins. And if you put that on a particular test, the test will light up like a pregnancy test when someone is pregnant, in detecting that that person has an active virus in their system. So that's the 3 tests: the PCR, the antibody, and the antigen test. Okay. We've been using those as our source of protection at this point. Basically, early detection, early treatment, quarantining folks, and making sure that anybody that they've been around also gets tested. We call that tracing. So what happens when somebody gets infected? What do we do at that point? Well, I'm sure I won't go into the many different debates about the treatments that have been discussed over the past year. I will say that at this point, the most consistent treatment that we've had out of the hospital has been an antibiotic, not so much to defeat a virus, because viruses are viruses and antibiotics take care of bacteria, but we use an antibiotic so we don't get a super infection or another infection on top of the viral infection, which typically happens when that pneumonia occurs. And we also use, in a second phase, a steroid or a immune suppressant drug. And that is to decrease that inflammatory response, that major inflammatory response that we call the cytokine storm. That's what we use as an outpatient. Now, if you're having headaches as a major symptom, we will treat the headaches with pain medication and also with the steroid. If their major symptom is respiratory, we will give you the antibiotics and the steroid, but we'll also tend to give you an inhaler like an asthmatic to allow for opening of the lungs, dilating of the lungs. As you all know, many people have respiratory issues, respiratory problems when they have this infection. And dilating the lungs allows for more airflow. And we want as much airflow and much oxygen as possible. One of the major symptoms, one of the major signs that somebody has for us in the emergency department is not so much the temperature of the patient, but the patient's oxygen level. We measure the oxygen levels and pay very close attention to that, because that is quite indicative of how badly the lungs are affected. And we've had some amazing accounts of patients coming in, walking in with an oxygen level that's supposed to be 99%, 100%, and in the low 60s. And we just, have been in emergency medicine just about 20 years now, and I don't think I've ever seen somebody walking with that low level of oxygen. Needless to say, those patients don't do well. And they walked in, they didn't think that they were that sick. Um, so, this virus is giving us quite an education um, on this new infection, this new variant of coronavirus. So we're learning as fast as we can, and we are moving in the right direction at this point in terms of trying to defeat and eradicate the virus. And speaking of defeating and eradicating the virus, we are finally at a position where we have vaccines available. I will tell you, I from the start was very skeptical about um, vaccines being created within a 1 year time period. And that's because vaccines typically take significantly longer than that. Um, the whole process of creating vaccines, um, uh, just to sum it up, has to deal with reproducing the virus through modalities and mediums such as chicken eggs, then weakening the virus, attenuating them, reproducing them again, hoarding them, isolating them, and hoarding them, and that takes it's a very, very long process. And so when we said that, back in February, or actually it was March, that we're going to work on a virus, we're going to try to have this virus, excuse me, a vaccine, and have that vaccine ready by uh, the end of the year, I was skeptical about that. And so it sparked my interest. So I wanted to follow this process very, very closely, and I did. Um, 4 companies were selected: Johnson and Johnson, aka Janssen, that's their medical division. They were given $1 billion to come up with a vaccine. AstraZeneca, also given $1 billion U.S. government, U.S. money, our money, to create a vaccine. Moderna, same thing, $1 billion. Pfizer, excuse me, same thing, $1 billion. And so those 4 companies set out on the race to create a vaccine that was going to be effective, and ready for a treatment of folks during this pandemic. The first to the finish line was Pfizer. Second to the finish line was Moderna. AstraZeneca is starting their reports. Johnson and Johnson is not quite finished yet. Johnson and Johnson is the only one working on a single dose vaccine, the only group. And that may be the difference, the only difference um, that may sway people to eventually take a Johnson and Johnson vaccine. Moderna and Pfizer did something that I was very impressed with. And as I said before, I was skeptical about it. I'm more concerned with my patients and constituents' health than Pfizer's, race to the finish line, or Pfizer's wanting to have, claims or sales or what have you. And so I was very scrutinous when it came to looking at how they made um, the vaccine. They used a technique that had not been used in vaccine production before. They used mRNA. Now, if you recall, earlier I said that after the virus was discovered, the genome for the virus was mapped. They had the whole DNA for the virus mapped out, which means they could take that DNA and reproduce the virus if they need to. What they did was take a small area of DNA that was coding for that surface protein. They took that out of the DNA. They reproduced that using techniques that some of you may be familiar with CRISPR, and techniques that have been out for about 10 years now in terms of reproducing DNA coding. They reproduced that and packaged that little that little messenger RNA portion, that RNA portion. They put it in a cholesterol packing. simple cholesterol. They added some very simple things. You may be familiar with it: salt, potassium, sucrose, which is glucose or sugar, a little bit of alcohol, and the cholesterol. I just gave you the ingredients for Pfizer. No mercuries, no metals, no additives, no preservatives to it. The way they preserve it is by keeping it cold. They package those vaccines at negative 94 degrees Fahrenheit, and they store them. And once you unthaw those vaccines, you have 5 days to use them. It's a little more complex than that, actually. Once they're room temperature, you have 6 hours to use them. But once they come out of the freezer, you have 5 days. When they come out of that deep freeze, you have 5 days to use them. That was the first thing that caught my attention. That was the most impressive thing to me. Why? Because I believe that many people have reservations about taking vaccines based upon not what the vaccine does for you, but what's in the vaccine. And so you've had, of course, many movements to discuss the use of vaccines and many people against it. But I don't think they're against the immunization process, because they would, many people say, well, let them catch it naturally and have a natural reaction to it. This is as close to a natural response that you're going to get from a vaccine. There is nothing else in there. If you're unfamiliar with the combination of chemicals I just mentioned, the salt, sodium chloride, potassium chloride, sucrose, these are the same things that are in saline. So when you come to the hospital, let me give you an IV, that's what's dripping into your arm. When you drink Gatorade, that's pretty much what you're drinking. Okay? So that is what's wrapped, that's what's around this vaccine, plus the mRNA portion that's just wrapped in a ring of cholesterol. So there's really minimal amount of material in that vaccine, which is why I was impressed, because I believe in minimal effective doses. I don't believe in excessive medication. I think you get exactly what you need and you move on from there. And that's what Pfizer has done. Now, Moderna, who came in literally 1 week behind Pfizer, did almost the exact same thing, except they added a compound which is the equivalent of, it's essentially vinegar, which allows for a longer shelf life. So that allows for a storage for approximately 1 month once it's unthawed. And those two vaccinations are 95% effective. 95% effective. Let's put that in perspective to, say, a flu vaccine. Flu vaccines range from 40 to 60% effective. These are 95% effective. Okay. I personally have taken the Pfizer vaccine. I've taken both dosages. Just yesterday, I posted on my website, I took a antibody test to show that I now have antibodies. In other words, I have that IgG protection that I was talking about. I did have, a little soreness in my arm after the second vaccine, but that was it. Now, I'm not saying that that's all that's going to happen to you. I'm just telling you what happened to me. So I want to kind of open up to questions at this point, but I just want you to have a little bit of an overview from December 19th, 2019 to where we are right now. And so we can open up to the questions and get into some of those, if you will.
Okay. Hello, Dr. Watson. This is Debbie Dusky. We met.
Hi, Debbie.
Hi. So one of the questions that is here is that somebody that has had COVID. Should they get the shot as well?
Yes. The answer to that is yes. The reason being is because the average person, as I said, their um, first time or one time exposure will produce about 90 days of IgG protection. That's what we know at this point. And so receiving the vaccine based upon studies, remember we studied between Moderna and Pfizer, we studied 77,000 people. And we know that the two-dose vaccines have produced 95% effective protection for them. So the answer to that is yes, we want to get people to 95% protection rate.
And then another question kind of along those same lines, if they get the first shot and they miss the second shot, or they're unable to get the second shot, or there's no vaccines available, what should the expectation be?
There is some degree of immunity after the first shot. As I said, there's some degree, it's not a full 95% protection. So the answer to that question is get the second shot when you can. We know based upon studies, all these regulations are based upon the studies, right? So there's not been much variance outside of that study. So we know that it's best to get it at between 3 to 4 weeks after the initial shot. But if it's 5 weeks, if it's 6 weeks, get it.
Okay. If someone is pregnant, should they get the shot?
My recommendation is going to be no. And I'm going to say that based upon the fact that the studies excluded anyone who was pregnant and anyone under the age of 16 and under. So pediatrics or our teenagers and pregnant women were excluded. Now, I know for a fact that some pregnant women have taken the vaccine. I know for a fact. And, and this is anecdotal, this is not studied. So I want to make that very clear. This is me asking them how they felt. They had no problems, they had no symptoms, but it has not been studied. So for me, and I'm going to give you recommendations that I would give to my patients or to my family or to myself. For me, I would say no, hold off on that.
Okay. Are these vaccines currently effective for the new strands that we're seeing come out with the COVID-19 virus?
What we've seen so far is that there is some protection. Again, the surface protein is what is in the vaccines, that the RNA sequence for the mRNA, the messenger RNA sequence for the surface proteins. So it doesn't look like there's enough variance in that surface protein to evade the body's immune response at this point. And that's including, the South African variant and the other European variant. So it's looking good for that so far.
You indicated, Dr. Watson, that you've already taken the antibody test and that you have antibodies after taking the COVID vaccine. Is that a typical, as soon as you get the second dose, that you have the you're not able to get the COVID-19 vaccine or the disease?
Well, so I waited 3 weeks after my second shot because there is it takes time for the immune system to develop the antibodies. As I remember, I said, particularly with IgG, those tend to come into effect about 14 days after your exposure. And so I waited 21 days after my exposure to check that I had immune status, and yes. So for me, that indicates that if I encounter, and I'm a high risk person, obviously, we've screened over 10,000 patients in 2020 with COVID. I'm in the emergency department, I'm in my urgent cares. So we're in front of COVID patients all the time. For me, it was very vital to go ahead and get that vaccine. So now I have some protection against COVID. I'm ready to travel, actually. I'm ready to get on a plane and go somewhere.
We have 3 questions that are kind of related. They're talking about different types of illnesses. One is it recommended for people that have rheumatoid arthritis? How does it impact other medications? And is there any information regarding it affecting fertility.
Okay, so let's tackle the first one. How does it affect rheumatoid arthritis? So people with rheumatoid arthritis are likely on immune suppressant medications. And although the immune suppressed community has not specifically been studied by this, it is always the recommendation that immune suppressed people get a vaccination when available to help stimulate their immune system. Again, the immune suppression is to suppress your immune system, and thus, if you get sick with COVID, you don't have the fighting forces. You have a delay in your IgM, your delay in your IgG, and that would compromise you, and your infection could be worse than anybody else's, than the average person's. And so, in order to give you some assistance, along comes the vaccine. That's why we recommend vaccines for those people. So the answer to them is yes. The second part, if I'm not mistaken, was what was the second part?
Does it impact other medications?
Yeah, so no, if you're taking medication, you can continue to take your medication. It will not give any adverse effects based upon medication. There's nothing in the vaccine itself that would be contraindication for any other medications. So yeah, you can whatever medication you're taking, you can take the vaccine.
Okay. And the third part was regarding fertility after taking the vaccine.
No, to this date and to our knowledge, the vaccines do not cause any infertility issues. Now, COVID may, because of the scarring of certain tissues, but the vaccine itself is no, it does not.
Okay. There's another question about, can I stop wearing my mask after I get the vaccine?
If you come to my house, you can, because we're vaccinated here. No, the mask is actually still going to be important. And the reason it's going to be important is because you, as a good citizen, still have to protect people around you. Mm-hmm. So you wearing the mask will prevent, continue to prevent spread of the virus. Now, let me make this very clear. Because your immune system is ready to defend against COVID does not mean that you won't pick it up and carry it in your nose. It won't make you sick, but you can still carry the virus and bring it to someone else. And so the mask and sanitizing and social distancing will still be in effect, at least until we're granted, herd immunity.
I think you may have already answered this about if you've already had COVID. I know you said to take it. Yes. I think they want to know how soon after they've had COVID can they take the vaccine?
Well, you can take it, once you recover. The recommendation, though, is if you feel that you can wait, because you, after having COVID, as I said before, many people would still have antibodies. If you feel that you can wait to allow other people to get the vaccine, that is, very kind of you. But you would, still be recommended to get it at some point, particularly, if you're after the 3-month mark. One way to determine whether or not you're still carrying protection for yourself is to get an antibody test and see if you're still holding IgG antibodies. But in general, if you don't have access to that, I would say as long as you're not still sick. I don't want you to, one, go out and spread the virus, and two, get an injection that may make you feel soreness in your arm, or lethargy, or headache. Those are the most common symptoms, by the way: soreness in your arm, fatigue, and headaches while you're already sick. Just wait till you recover and then go get your shot.
Okay, I have two final questions.
Yes.
The first is there a strand of COVID-19 in the vaccine?
No. There's no, there is, what's in there is an mRNA production of synthesized sequence for the surface protein, that surface protein that I kept talking about. So the rest of it is not in there. There's no reproduced virus that's in there. Previously, old techniques would be to reproduce the virus, then weaken it, and then give it to you. That's called an attenuated virus, attenuated vaccine. We're not doing that. This is why these the Pfizer and Moderna, they've done something that's never been done before. They're using genomic sequencing to reproduce just that portion of it, which is then going to protect you. So if you get the vaccine and then you get body aches or chills or something like that, that's your immune response. That's not COVID causing that. That's your body responding to it, which is actually a good sign. That means that your body's initiating an immune process.
So we just got a couple more that are questions about children. Is there a new strand in children, and are children, even though they're asymptomatic, can they still spread the virus?
Anybody who's asymptomatic can spread the virus. This is why it's important to get routine testing after exposures. Even if somebody has the slightest symptoms, particularly the runny nose, you would be amazed how many times I've tested people and they said I had no problems, no symptoms, and they're positive. And then, I ask him again, well, are you sure? Well, just a little runny nose. That runny nose, remember, in the beginning, I said Corona just used to cause a little runny nose and some cold symptoms. All right. Some people still get that little runny nose and cold, and that's it. And their immune system is strong enough to ward it off, but they're spreading it. They're still spreading it. So that's why it's important to get tested when you have any sort of symptoms.
And do we know how long the vaccine will protect us?
We don't. We
Okay.
don't.
Well, there's a lot of thank yous in here, Dr. Watson, from all of the staff that has been part of this presentation. I'm going to now turn it over to the superintendent so that they can move forward with the rest of the presentation. Thank you so much, Dr. Watson.
My pleasure. My pleasure.
Thank you, Dr. Watson. The three of us, Dr. Patterson that's here, Dr. Thomas, we actually represent a unique group. At one time, you would have been taught, we would have been referring to all superintendents because we would all house children. But we're part of a very small group in the South suburban area that are privileged to have children in front of us. And so that's why your presentation was so important to us. And that's why we're determined to do everything that we can to make sure that our teachers have as much protection as they can, administrators also. But we've run into a few roadblocks. And of course, you're well aware that we do not, as a nation, have a stockpile of vaccine. We all know that now. We're aware also that President Biden has tried to pick up the pace. And so we understand that in our state, we should receive 15% more vaccine this coming week than we have in the past. But new information that we obtained today as a group, it was shared with us because many of our elected officials want to try and be as helpful to us as possible. There's 650,000 people in Group 1B. That's a lot of people. But in previous weeks, our state has been getting 50,000 doses. So looking at that, we know that this is going to be something that we're going to have to look at, not as an immediate kind of thing, because we actually, Dr. Thomas, we're all organized. If we had, and we just finished talking to some elected officials, and if anybody's on this call, if you have 1,475 doses, we're ready.
We're ready for them.
So
Yeah,
we have
100%.
you, we have nurses, and
Yeah,
so we're ready.
to go.
We're ready.
Mhm.
But that is not the case as we sit here now. And so, okay, we are going to make it possible and search all of the websites and take advantage of as many appointments as we can, even if it's on school time. I think we're in agreement with that. But it's our understanding also that there will be school sites. And I do want to introduce the superintendent that volunteered, I think you volunteered, to host that because Dr. Patterson and I have been working with him. We have sufficient nurses. We think that we're going to depend on you for training because you're the expert. But what we would like to do is to, when the vaccine becomes readily available, not only make sure that our teachers are protected, but we want to reach into the community and do everything that we can. Having said that, I'd like to introduce Dr. Thomas. Many of your own people are on the Zoom, so we don't have to do that. But we've been working together on this project, and
well, we have, and before I just kind of go down that road, I truly understand why Sherlock Holmes had his Dr. Watson. So truly appreciate you
Who?
joining.
I've never heard that joke.
Never heard that one before. Huh? I just had
20 years. I've never heard that joke.
But we as a collective have spent an extraordinary amount of time efforting as much support as we can to ensure that the Southland is well represented when those vaccines arrive. We do understand that from our conversations that there is a shortage, but when they do arrive, we're trying as hard as we can to make sure that we are in front and ahead so that our staffs can have the protection that they truly deserve. But in the meanwhile, we are prepared. District 227 has been working with Cook County for quite some time. In fact, the site that we have identified was already trained and had a plan for mass vaccinations in the event that we had a biochemical attack. So we are truly ready to aid and assist, and with partners like 144 and Southland and 162, we're very confident that we can get all of our staffs in, get them vaccinated, and beginning to help and bring our communities up to speed as well. So we're really grateful for you taking this time to provide more knowledge in the last 40 minutes or so than I've gotten on CNN in the last year. So I truly appreciate the detail and the expertise that you bring to the table.
Yeah.
And so I'll pass the mic on to Dr. Kamako Patterson, who's also here with us. And man, you just don't understand how much power is to each side of me. I'm just so surrounded, and it's amazing. So I'll pass the mic to Dr. Kamako Patterson, Prairie Hill School District 144.
Hi, good evening, Dr. Watson.
evening.
Everything has pretty much been said. So we are so appreciative of the knowledge that you have shared with us this evening. I do think that it is alleviating concerns and answering questions from our staff members, and that is just priceless. So we appreciate that, and we look forward to the partnership. Absolutely.
Absolutely. Myself as well. I'm very, very anxious to come full circle. When we took on this task a year ago, we were in the Southland. I was with some hospital, and we were prepping for what we knew was coming. And I was very disappointed when a lot of the hospitals decided to back out of the preparation and just kind of took a wait and see what happens. But we saw what happened, and my group decided to step forward and do what we knew we could do. And so now the vaccine is here. We're very anxious to complete the circle and bring definitive treatment and prevention to the community that we've been so deeply involved with for the last year. So we're very excited. We're very excited.
And for our staffs, I just want to add that we're not only waiting for the public health officials to provide assistance and support. We've reached out to the Advocate healthcare system. We've reached out to South Suburban Hospital, which is also a part of that system. St. James Hospital, and we're working with Blue Cross Blue Shield and Albertsons to see what we can do to garner any vaccines that may be out there that we can start the process early. So we continue to advocate for our districts. We continue to try to find ways to be proactive and not wait for somebody to hand us something, but we're actually actively going out there trying to get it.
Thank you, Dr. Watson. And we still do encourage all staff, if you see an opening through a link and there's an opportunity, then take the vaccine as soon as you can. But know that we as a group are doing everything that we can. And in addition to the companies that Dr. Thomas mentioned, we're on the list for Walgreens, Osco. But while I was sitting here, I got to leave because a couple of elected officials are trying to locate additional vaccines for us. So we will do everything possible to make sure that everyone that works for us and in our individual communities has an opportunity to take the vaccine as soon as possible. But thank you so much, Dr. Watson, and thank everyone that's on this Zoom call. And you are at home, but we will take the opportunity to go home and to be just safe, just as you are. So thank you and good evening.
Good evening, everybody.
Thank you.